Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's video. Today's video is all about a condition known as tarsal tunnel syndrome. Just that, it's a peripheral nerve lesion found in the lower extremity. And tarsal tunnel syndrome is frequently known as the great masquerader. And the reason it's called that is because the signs and symptoms associated with tarsal tunnel syndrome can commonly be confused with other conditions. And so tarsal tunnel syndrome itself ends up being under-examined, under-evaluated, and many times under-diagnosed. Specifically, being confused with the more common condition of plantar fasciitis. And tarsal tunnel syndrome and plantar fasciitis have many symptoms in common, and we'll go through some of the distinctions that separate plantar fasciitis from tarsal tunnel syndrome here as we go along. Now, in a few moments, we're going to have a live subject, and I'm going to demonstrate the physical examination maneuvers associated with tarsal tunnel syndrome. But before we get to that, I just want to review some of the anatomy of the nerve involved at the tarsal tunnel. So I want to trace the anatomy of the nerve from the ankle all the way back up into the lumbar spine so that we're all on the same page and we're all refreshed about the anatomy involved. Okay, so let's go all the way up to the lumbar spine, and remember that the lumbar spine gives off nerve roots, and those nerve roots immediately after they come off of the spinal cord they divide, and they divide into dorsal primary rami and anterior primary rami. And the dorsal primary rami, they go on to innervate the lumbar paraspinal muscles. The anterior primary rami then divide, and they divide into anterior and posterior divisions. Now, the posterior divisions of L4, L5, S1, and S2 combine to form the common peroneal nerve. The anterior divisions of L4, L5, S1, S2, and also a small slip from S3 combine to give us the tibial nerve. Now, the common peroneal nerve and the tibial nerve then become conjoined in the same connective tissue fascia. It's called the epineurium. So before we have a conjoined nerve, we have two separate nerves, the common peroneal nerve and the tibial nerve. Each of those are wrapped in connective tissue. We call it the epineurium. These epineuriums then become conjoined, and these two nerves become encased in the same singular connective tissue sheath, a single conjoined epineurium. Now, the epineurium, if we trace it back up into the spinal cord, becomes continuous with the dura of the spine, correct? But down outside of the spinal cord, these two separate nerves join to give us what we know as the sciatic nerve. Now, the sciatic nerve is not actually a nerve itself, it's just the encased sheath of both the tibial nerve and the common peroneal nerve. So we have this large structure that we call the sciatic nerve. So the sciatic nerve then leaves the pelvis underneath the sciatic notch, and it continues down into the back part of the leg. Now, in the posterior aspect of the leg, the tibial portion of the sciatic nerve gives off some branches to innervate 3 of the 4 hamstring muscles, and gives off a small twig to innervate the adductor magnus muscle. Okay, so the tibial nerve goes on to innervate the semitendinosus, the semimembranosus, and the long head of the biceps femoris, and then also gives off a small twig to innervate the adductor magnus in combination with the obturator nerve. In the posterior aspect of the thigh, the common peroneal nerve gives off a small branch to innervate the short head of the biceps femoris. So that's kind of interesting that the only structure innervated in the posterior thigh by the common peroneal nerve is the short head of the biceps. All of the other hamstring muscles are innervated by the tibial nerve. And this provides the basis for the hamstring reflexes. The medial hamstring reflexes are considered to be an S1 reflex mediated through the tibial nerve. The lateral hamstring reflex, specifically the short head of the biceps tendon reflex, is considered also to be an S1 reflex, but mediated through the common peroneal nerve. So that can have some clinical application there to distinguish a lesion with the tibial nerve from a lesion from the common peroneal nerve. Okay, so after those branches are given off to innervate the hamstring muscles, the sciatic nerve then continues down the posterior aspect of the leg, and then about 2 inches above the knee, the sciatic nerve then gives off its 2 original nerves, and the tibial nerve and the common peroneal nerve separate out from this conjoined epineurium. And the tibial nerve then passes medially behind the knee in the medial aspect of the popliteal fossa, and the common peroneal nerve passes laterally in the popliteal fossa. And sometimes you might see the nerves referred to in various textbooks or anatomy references calling the tibial nerve the medial popliteal nerve, and the common peroneal nerve is referred to as the lateral popliteal nerve, because that's how they split out as they pass through the popliteal fossa. So the common peroneal nerve splits off and goes laterally in the popliteal fossa, comes around the head of the fibula, and then goes on to innervate structures in the anterior aspect of the lower leg. So let's discard the common peroneal nerve for now and focus in on the tibial nerve. So as the tibial nerve passes through the medial aspect of the popliteal fossa, it then descends into the lower leg, and it sends off branches to the popliteus muscle, to the 2 heads of the gastrocnemius muscle, to the soleus muscle, to the tibialis posterior muscle, to the flexor hallucis longus muscle, and the flexor digitorum longus muscle. Okay? Then the tibial nerve then descends the back of the leg and wraps around behind the medial malleolus. And at this point, at the level of the ankle, the tibial nerve becomes named the posterior tibial nerve, because it then travels behind the posterior aspect of the medial malleolus of the tibia bone. Okay, so we're at the medial malleolus. Now, at the medial malleolus, several various configurations of the posterior tibial nerve exist. Now, there are at least 3 and possibly even 4 and possibly even more in the case of an anomalous configuration of the posterior tibial nerve, but there's at least 3 or 4 branches that then come off of the posterior tibial nerve. And many different configurations exist as to where these branches come off. Now, typically most anatomy references and sources will state that the first branch to come off the posterior tibial nerve is the medial calcaneal nerve. the medial calcaneal nerve. Now this is important because the medial calcaneal nerve can pass in several different ways through the tarsal tunnel, which I'll describe in just a moment, on its way to its termination on the middle aspect of the calcaneus bone. And this is strictly a sensory nerve. But some anatomy textbooks demonstrate the medial calcaneal nerve as coming off the posterior tibial nerve above the tarsal tunnel and then traveling superficially above the tarsal tunnel to innervate cutaneous structures on the medial aspect of the calcaneus. Some anatomy references indicate that this medial calcaneal nerve pierces the connective tissue forming the roof of the tarsal tunnel. Some anatomy references indicate that this nerve also passes underneath the tarsal tunnel along with the other branches of the posterior tibial nerve as well. So various anomalous configurations exist. For our purposes, let's imagine that this medial calcaneal nerve comes off of the posterior tibial nerve above the tarsal tunnel and travels superficially, meaning on top of the connective tissue that forms the roof of the tarsal tunnel, and then goes on to innervate cutaneous structures on the medial aspect of the calcaneus. So that's one branch. Then, as the posterior tibial nerve continues down behind the medial malleolus, the posterior tibial nerve becomes covered on top by a piece of connective tissue, and this is known as the flexor retinaculum. Now, the flexor retinaculum is continuous with both the superficial and deep aponeuroses of the leg, and it's also continuous with the tendons of the tibialis posterior, the flexor digitorum longus, and the flexor hallucis longus. So there's this confluence of connective tissues that form what we refer to as the flexor retinaculum. And here's the flexor retinaculum. It's attached to the medial malleolus here and the medial aspect of the calcaneus below. And the posterior tibial nerve then passes underneath the flexor retinaculum, having already given off a branch to innervate the medial aspect of the calcaneus. Now again, various anomalous configurations exist, but this posterior tibial nerve, as it passes through the tarsal tunnel, gives off at least 3 more branches. And those branches can come off early before the entrance into the tarsal tunnel, immediately within the tarsal tunnel, or perhaps after the exit of the posterior tibial nerve from the tarsal tunnel. So anomalous configurations exist. But let's just imagine that these branches come off of the posterior tibial nerve as it passes underneath the flexor retinaculum. Well, as it passes underneath the flexor retinaculum, also accompanied by at least 4 other structures, including the posterior tibial artery, the tendon of the tibialis posterior muscle, the tendon of the flexor digitorum muscle, flexor digitorum longus muscle, and the tendon of the flexor hallucis muscle, the posterior tibial nerve branches off to give us the medial plantar nerve, the lateral plantar nerve, and the inferior calcaneal nerve. Okay? Okay. So the medial calcaneal nerve and the inferior calcaneal nerve are simply sensory nerves. So we don't have to spend a lot of time discussing them, except to say that it's these nerves that innervate the cutaneous structures on the medial aspect of the calcaneus and then also on the undersurface of the calcaneus. And this is where it can be confused with plantar fasciitis, because when that nerve is irritated first at the tarsal tunnel and then secondarily underneath the calcaneus by repetitive stepping on those nerve endings, that can simulate the pain and be confused with plantar fasciitis. Now, one important distinction between plantar fasciitis and heel pain associated with compression of the posterior tibial nerve is that plantar fasciitis is pain that's reproduced with weight bearing. It's pain that's associated with weight bearing, whereas the heel pain that's associated with tarsal tunnel syndrome and compression of the posterior tibial nerve is unrelated to weight bearing. So there's an important clinical distinction. So posterior tibial nerve passes underneath the flexor retinaculum, giving off three branches: the inferior calcaneal nerve, the medial plantar nerve, and the lateral plantar nerve. Now, 1, 2, 3, any combination of all of these nerves can be compressed in the tarsal tunnel due to space-occupying lesion within the tarsal tunnel. So what kind of things could occupy space in the tarsal tunnel? Let me ask you. What type of structures, anomalous structures, could occupy space in the tarsal tunnel, thereby causing compression on the posterior tibial nerve? Well, how about a varicosity of the posterior tibial vein or other superficial veins in this area? Varicosities could occupy space and compress the posterior tibial nerve. How about a lipoma, a little fatty deposit? How about a ganglion? How about hypertrophy of the tendon sheaths of the tibialis posterior, the flexor digitorum longus or the flexor hallucis longus? All of these things occupy space within this fibroosseous non-expansile tunnel and could cause compression on the most delicate of the structures passing through the tarsal tunnel, which is the posterior tibial nerve. So if the medial plantar nerve, for example, is compressed, we're going to see symptoms associated with that. And the medial plantar nerve is a mixed nerve. It has both sensory and motor functions. So sensory disturbances involved with dysfunction of the medial plantar nerve would involve pain or any of the paresthesiae located in the great toe, the first toe, the second toe, and one half, the medial half, of the fourth toe. In fact, the medial plantar nerve of the foot is exactly analogous to the median nerve in the hand, right? Isn't that what the median nerve innervates? The thumb, the index, the middle, and one half, the radial half of the ring finger, correct? So medial plantar nerve does the same. Same sensory distribution on the plantar surface of the foot. Now, the median nerve also has motor function, and the most testable and the most directly accessible muscle that we test to assess for the medial plantar nerve is the abductor hallucis muscle on the medial aspect of the great toe that performs abduction of the great toe. And we'll demonstrate that muscle test in just a moment. Now, if the lateral plantar nerve is compressed in the tarsal tunnel, then we'll have sensory and or motor symptoms associated with that nerve. And the distribution of the lateral plantar nerve in the foot is exactly analogous to the distribution of the ulnar nerve in the hand. Isn't that fascinating? Isn't that amazing? It actually makes the neurology of the foot kind of simple to remember. So in the foot, the lateral plantar nerve innervates the lateral aspect of the fourth toe and the entirety of the pinky toe, as well as the lateral aspect of the foot. And for motor testing, we test the abductor digiti minimi along the lateral aspect of the pinky toe. Okay, so there's the neuroanatomy involved with tarsal tunnel syndrome. And tarsal tunnel syndrome is simply the name that we give to compression of the posterior tibial nerve as it passes through this fibroosseous tunnel behind the medial malleolus. So before we get on to our live subject, let's describe the borders of the fibroosseous tunnel so we're clear on what it is we're testing when we have the live subject. The fibroosseous tunnel is formed laterally. Laterally, if we're talking about, for example, my left foot, is formed laterally by the bony surfaces of the calcaneus, the sustentaculum tali, the talus, and the medial aspect of the navicular bone forms the osseous portion of the tunnel. And then the fibrous portion of the tunnel is simply a covering across the top by the flexor retinaculum. And the flexor retinaculum, as we said, is continuous. It's connective tissue that's continuous with both the deep and superficial aponeuroses of the leg, and also continuous on its deep surface with the tendon sheaths of the tibialis posterior, the flexor digitorum longus muscle, and the flexor hallucis longus muscle. Okay, so that's the anatomy involved. Let's bring on our live subject now, and we'll demonstrate the physical examination involved for assessing tarsal tunnel syndrome.